Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and turn in the program evaluation and give us any ideas that you might have in regards to future topics or future speakers, and we'd be very appreciative of those ideas. Today it's my pleasure to reintroduce Dr. Trevor Van Schooneveld. Dr. Van Schooneveld is an internist and an infectious disease specialist. He is an associate professor of internal medicine in the infectious disease department at the University of Nebraska Medical Center in Omaha. He's also the director of their infectious disease fellowship program. Dr. Van Schooneveld has been the recipient of several honors and accolades during his career, and including the fact that he is perennially recognized as one of the top teachers at the University of Nebraska Medical Center, and accordingly we're very happy that he's here today to update us on biomarkers and infectious disease. And please join me in welcoming Dr. Van Schooneveld.
Thanks, appreciate it. All right, well, thanks for having me. The drive is not too bad, about the shortest trip I can take, so it's nice. So I got asked to talk about biomarkers in infectious disease, particularly about procalcitonin. I understand you guys have procalcitonin, and we're going to talk about how we use some of these biomarkers, particularly procalcitonin. So these are my disclosures. These are the objectives. Hopefully you guys will understand what the heck is procalcitonin and what does it do, some things that can maybe impair its utility, and then how to utilize it and other biomarkers in your practice. Because really what we're looking for is how do we improve patient care. So why do we talk about biomarkers of infectious disease? Well, if you look at the data, we don't do fabulous with using antibiotics. Depending on how you measure it, how you score it, about up to a half of antibiotic use is either not necessary or the wrong drug. All that misuse leads to antibiotic resistance. You can't, open a newspaper or a magazine, but every month you see something about antibiotic resistance. And those antimicrobials are also bad for our patients. So if they don't need them, why give them the toxicity? And then all of that drives C. diff incidence. And so we need to be wiser with our antibiotics. The problem is diagnosing infection is kind of hard, right? I mean, it's very ambiguous at times. We look at studies of sepsis, only determine the actual etiology up to maybe 2/3 of the time. That's pretty generous. Usually it's less than that, and people are called sepsis because they look like they're sick with an infection, and they got some antibiotics and they got better. For pneumonia, the highly aggressive diagnostic studies where they do every test you can imagine to sort out why somebody has pneumonia, we only make the diagnosis about half the time or less. The yield of blood cultures is so low, people have debated whether we should even do them routinely on people with pneumonia. And sputum cultures, about half of people can't even produce sputum. And once you start antibiotics, typically within 12 hours, pneumococcus, you can't find it in the sputum. So it's very difficult to sort all this out. And that's what drives a lot of antibiotic use is, I don't know whether they have infection or not. And so we're going to kind of cover our bases. And so what we'd like is something that helps us determine if somebody has an infection or not. Now, I like to tell people we have this wonderful device at the University of Nebraska by every patient bedside that we shake up and try and sort it out, and it tells us infected or not infected. I wish it were that simple. I wish we had such a device, and I could tell my critical care docs, no, not infected, don't worry about it. But we have to use data, and some of the data we use are things called biomarkers. So what's a biomarker? Well, it's a measurable characteristic to reflect severity or presence of some disease state or some physiologic state. We use biomarkers in all parts of medicine. There's lots of cancer biomarkers to see if you can use the latest mAb that costs $1 gazillion. But in infectious disease, we use them quite a bit, and I'll talk about some of the common ones we use. So the ideal biomarker would be sensitive, wouldn't miss any disease people, and it'd be specific. It wouldn't be positive people who don't have a bacterial infection. It'd be nice if the higher it was, the more likely they were that they were infected. So 20 meant something much more meaningful than 0.2. It'd also be nice if, sicker people were, the higher the numbers were. Just helps to make sense physiologically. It'd be really nice if it went down as people got better, so maybe we could use it to decide how long to treat people. One of the things that often confounds a lot of our biomarkers is immunosuppression, other things that can throw that off. Plus, it's got to be fast. A biomarker that comes back a week later, pretty much useless. When I was a fellow at the VA, we had procalcitonin, but it was a send-out test. And so by the time we got the results back, the patient was usually discharged. And then it's got to be cheap, or, what's the whole point? So we do use biomarkers in clinical practice. These are some of them. Things like fever, leukocytosis. I mean, these are very sensitive, very easy to measure, but pretty nonspecific, easily confounded by other things. Cytokines people have looked at. They go up really fast. They're pretty sensitive, but they're really variable. And we haven't really sorted out how to use them real well because they often have very short half-lives and it's quite expensive to measure. C-reactive protein, the pediatricians have been a big fan of CRP for a long time. I think as an internist, we use CRP some, but not usually to sort out bacterial infection or not. There's just too many reasons people can have elevated CRPs where we're rarely going to hang our hat on whether I'm going to give antibiotics or not. The other thing about CRP is it's a little slower to go up, takes about 24 hours to peak, and so not so useful right at the initial point of decision. Procalcitonin, which I'm going to talk about, is right now our most specific biomarker for bacterial infection. It's pretty rapid. It is more expensive than a CRP, and it's not useful, and this is an important point, for localized infection. So a small localized abscess, cystitis, osteomyelitis, it's just not useful in those because it's really driven by systemic cytokines. So that leads us into the next thing we should talk about is, well, what the heck? Procalcitonin, where does that come from? So it's a product of the calc genes, and there are actually 5 different calc genes, but usually they are used to produce calcitonin, right? They produce this initial protein precursor here, and let me bring up my laser pointer on the screen. This protein precursor here that's created in the cell, it's processed then in the Golgi apparatus and secreted, and that's in a highly regulated parathyroid, cells in the thyroid gland there, very highly regulated, gastrin, calcium, all those things that I don't quite remember from endocrinology. And at normal physiologic levels, it's really low, like picograms levels. Now what happens under systemic inflammation driven by cytokines and bacterial lipopolysaccharides, it actually stimulates what's considered a hormokine or a systemic production of procalcitonin. This isn't just from those cells, it's from a variety of tissues, which I'll show you here in a second. And it's not post-translationally modified in the Golgi, it's just spit out as procalcitonin immediately. The nice thing about it is it's actually inhibited by the cytokines that are produced during viral infection like interferon gamma. And that is very rapidly produced. One of the nice things about procalcitonin is you can't lose the tissue or the cells that produce it, because this is an experiment where they looked at procalcitonin production under normal conditions, and this is under sort of induced sepsis conditions. You can see a variety of tissues produce this. It's produced ubiquitously, so just killing off your white cells won't get rid of this. What drives it is really cytokine production. These are some experiments generated using lipopolysaccharide injections, and what they show is that with lipopolysaccharide injection, you have very rapid induction of cytokines, which rapidly drop off depending on the cytokine, with procalcitonin following within 6 to 12 hours and hitting its peak. And you can see CRP follows another day later. The other nice thing about procalcitonin is its half-life. It's very predictable if the infection is controlled. It's going to drop by about half per day if you've dealt with the problem. And so if it's 20 today and you've got them on the right antibiotics, you can anticipate it being around 10. Might be 12, might be 8, but around there. And the dynamics of procalcitonin, I think, are what's really useful. An individual value can be somewhat helpful in an ambiguous situation, but the dynamics of the values are even more useful. These are a couple of studies looking at neutropenic fever patients. What they looked at is what happens to people's procalcitonins when people have bacteremia, when they have severe sepsis, and how they're doing clinically. And here in panel A, you can see people with bacteremia responded to therapy, got better, procalcitonin dropped rapidly. Similar severe sepsis, as people got better, their procalcitonin dropped. Here are people who didn't respond to therapy for whatever reason, and the procalcitonin didn't get better either. It mimicked physiologically what's going on. And so this is another study that looked at the PCT kinetics in ventilator-associated pneumonia, survivors versus non-survivors. They measured it at day 0 and day 4, and what you can see here is at day 0, didn't really, there wasn't that much difference between survivors and non-survivors. The major predictor was survivors, the people who got better, the procalcitonin went down. If it didn't go down, that's not good. What does that mean? That means to me, something is wrong. Have I missed with my antibiotics? Have I not dealt with the source of infection? Something has gone wrong. Not always, but I'd say it always makes me concerned about what am I missing? Am I missing something? Is something gone wrong? So I could spend like, that could have like been an hour worth of talk to sort of go through all of, to get to this slide. So we're doing the quick and sort of, I'm skipping a whole bunch of studies. But what I'll tell you is this is the most specific biomarker for bacterial infection we have. Is it perfect? No. I'll show you some issues that we have here in a couple slides. But it is the most specific that's out there right now. The nice thing about procalcitonin is it correlates nicely with severity of disease. So if you look at it based on SOFA scores, so organ dysfunction score in the ICU, the higher the SOFA score, the higher the procalcitonin tends to be in people with sepsis. If you look at Curve 65 scores, people with the Curve 65 score of 5 are going to have a lot higher procalcitonins than those with the low score. And so it has a nice mimic of what we see physiologically. It rises rapidly, typically within 6 hours of insult, and the half-life's about 24 hours, very predictable. I've seen it go from basically 0 to greater than 150 in 12 hours in people with bacteremia. So that's very useful when we're making clinical decisions, because that means that, hey, if I can check now and if it's fine, maybe 6 hours later I check again and suddenly it's high, boy, you know, I better do something about that. And I've used that often in the ICU, where we often have these patients who are like, oh, are they going south? Are they not? What's happening? I can't tell. A stable procalcitonin is very reassuring, where a rising one will often prompt me to sort of say, well, maybe we do need to do something. The other nice thing is it's not impaired by neutropenia or other immunosuppressive states. Now, there are some things that can make it go up that aren't infection. And one of those is actually major surgery. And there are a whole bunch of studies that I could show you like this. This top one here is procalcitonin levels in people who underwent cardiac surgery, or these are liver transplant patients. But I could show you the same thing with heart surgery. Basically, any sort of major physiologic stress is going to drive those cytokines, which will drive that procalcitonin up. The nice thing is, it'll go back down to normal if there's nothing else going on. So no postoperative infection develops, should go back to normal. These are liver transplant patients who either develop rejection or infection. What you can see here is people who develop rejection, no change in procalcitonin, which often can be a little difficult to tease out from infection. People with infection, rapid rise. And so it's important we sort of recognize the things that can confound our procalcitonin. So like I said, any major physiologic stress is going to drive cytokines and drive procalcitonin release. So being born, it turns out, is a big stress. We never get to ask people, but it turns out, and so generally in the first 72 hours of life, it's a little hard to interpret. But after about 72 hours, most pediatric people feel you can interpret it as normal. Any sort of severe trauma, surgery, cardiogenic shock, burns, our people who come into the hospital who've been run over by trucks and things like that, their procalcitonin is going to go up because it's a major physiologic stress. And then any sort of unresolved stress, so ongoing, cardiogenic shock that's unresolved, perfusion abnormalities, a code that went for 30 minutes, all those, because of the tissue ischemia, the cytokine release, are going to drive that. And so you have to anticipate that in interpreting the levels. There are other non-bacterial cytokine reasons you can have it. Some forms of vasculitis, an acute graft versus host, can sometimes drive this. Malaria, which we don't see too much of here, but also fungal infections can drive this. So candidemia, typically not going to be as high as we see in bacterial sepsis, but we can certainly see that, see procalcitonin go up. And then chronic renal disease. So this is a topic of much debate. How does renal disease impact procalcitonin levels? I'll tell you my sort of gestalt of reading a whole bunch of papers, and there's a nice review article if you're interested last year in Clinical Infectious Diseases. But a low level is still a low level and still useful. People with renal disease don't clear it quite as well. People with renal disease also have some sort of underlying baseline inflammation. If you measure HSCRPs in them, they'll be higher. And so their procalcitonin levels in the 0.25 and 0.5 range, hard to interpret. A 5, still significant. And so it's those sort of borderline areas where it gets a bit more difficult to interpret. But a negative is still a negative. And then there's some dysregulated things where if you give people like antithymocyte globulin or alemtuzumab or IL-2, they'll get dysregulated procalcitonin production because their T cells are all being killed off or things like that. And some of that can be pretty prolonged. And then paraneoplastic syndromes where you're producing calcitonin would produce lots of procalcitonin. So important to know these things, particularly this top one, for interpreting your levels. So we're talking about procalcitonin. What I'm not going to talk about is the gazillions of observational trials that have been published on its utility for diagnosing bacterial infection. I'm not going to talk about the 5, I think now 6 meta-analyses that have been published on how good a diagnostic marker it is. They've had conflicting findings. I think I have one slide later. Going to give you any sensitivity, specificity, positive, negative predictive value. Why is that? Because where does the rubber really meet the road? It's when we talk about what happens when we treat people using this. And so the levels of evidence, as I kind of think of them, is we do a bunch of observational studies and see how does procalcitonin perform in 100 people with bacterial infection and 1,000 people presenting to the ED with fever and things like that. And then we do some meta-analyses summarizing those. And those are all sort of difficult to put together because sometimes they'll use different assays. They'll use different cutoffs. They'll be in different clinical settings, different prevalences of disease. There's some selection bias in some of those studies. They'll have different gold standards. We already talked about the difficulty with our gold standard of diagnosis of infection. And so there's some real issues here. And so the question is, what happens when we base our antibiotic therapy on procalcitonin? Do we stop antibiotics and a bunch of people die? What happens? Well, fortunately not, or we wouldn't be talking about it. But this is where we have the best evidence. I'll tell you, there's a ton of data on a whole bunch of different disease states. But the best data in the randomized control studies are in respiratory tract infections and sepsis. And so that's where we're going to focus. The very first randomized control trial was published 12 years ago in Lancet. It was a single-center, randomized, single-blinded study. It was patients presenting to the ED with lower respiratory tract infections, COPD exacerbations, asthma, pneumonia. And what they did is they used a simple algorithm. They said if your procalcitonin is less than 0.25, we would suggest you not give antibiotics. If it's greater than 0.25, we'd suggest you do. And the lower or higher it is, the stronger the recommendation. They also said if you don't start the antibiotics, repeat a level in a few hours. And they allowed physician overruling. An important point, in all studies of procalcitonin, they allow physician overruling. And that's because as clinicians, we treat patients, not numbers. And so no number should ever singly be the key thing that drives everything we do. Data we put into our decision making. This is the outcome of that first trial. They measured one level at presentation in the ED. Showed a significant decrease in antibiotic use in every single clinical group. You can see the decrease was not that much in CAP, although significant, but was huge in those syndromes like exacerbation COPD, bronchitis, where we know that bacterial infection is a small portion of those patients. And some of them probably have a bacterial infection, but a lot of them have viruses and other things going on. Good news is they didn't kill anybody. Nobody was in the hospital shorter, and they cut antibiotics in about half. We know we overtreat people, so how can we safely identify people who we shouldn't treat? And this study seemed to suggest this is useful. So that's one study. This is the other respiratory tract trial I'm going to show you. This is the PROHOS study, is the largest trial done to date, multi-center, non-inferiority, randomized trial of adults, same population, presenting the ED, but what they added here were they added repeat values at day 3, 5, and 7. And then they added to that, same rule, 0.25 or greater, treat, less than 0.25, stop. What they added was on the repeat, if the levels were less than 0.25, they said stop. Or if they were 80 to 90% decreased from the peak, they said stop the antibiotics. And they had the same population. This is the outcome of that study. This is the overall antibiotic use. Basically, they showed decreased antibiotic exposure, 35% overall. So ranging anywhere from about 1/3 to 2/3. The greatest decreases were, again, in those syndromes where we need less antibiotics. Overall antibiotic prescription rate, 12% decrease. Biggest decreases up to 27% in the COPD group. And what was the clinical outcome? So the antibiotic prescription rate decreased absolutely 12%. Mean antibiotic exposures decreased about 1/3. 30-day adverse outcome no difference. Actually, maybe slightly better in the procalcitonin group. Antibiotic adverse event rate significantly decreased in the procalcitonin group. Not surprising, less antibiotics, less adverse events. And then mortality, no difference. So I'm going to show you one or two other studies that I think are useful. This is a study just of CAP patients. Same thing, randomized to PCT versus usual care. This is antibiotic duration in procalcitonin group. You can see they're getting people off of antibiotics much more rapidly. They found no difference in the complication or the clinical outcomes. And this is why I like this study, because they stratify people on pneumonia severity class and by bacteremia. What you can see here is, in people who had pneumonia severity class of 1 to 3, they got about 13, 14 days. In 4 and 5, they got about 13, 14 days. Now, that's longer than the guidelines would suggest, but this was done, published in 2006. Similarly with bacteremic, if you weren't bacteremic, you got about 13 days, and if you were bacteremic, you got about 14 days. So that's sort of the standard one-size-fits-all that we've advocated for a long time. Using procalcitonin, people with less severe pneumonias by a severity index got shorter course, versus those with more severe got longer course. Similarly with bacteremia, procalcitonin-based management got longer course. And so again, a little of this may be physician overruling, but this really mimics physiologically what we'd expect. Sicker people probably need a longer antibiotic course. People with bacteremia probably need a longer antibiotic course. So reassuring that this sort of fits with what makes sense clinically and what our experience is. One slide on a COPD trial. This was done with 208 patients with pretty significant COPD. The one thing to point out here is they used a little different cutoff, still the 0.25 for starting antibiotics, but here they said the 0.1 to 0.25 depends on how sick they are. They're really sick, start some antibiotics, and then stop them early if the procalcitonin goes down. They decreased antibiotic use from 72% to 40%, and there was no difference in clinical outcomes. And they actually followed these patients for 6 months to make sure they didn't have increased exacerbations or anything like that. So again, lots of data in different settings looking like it's safe and effective at decreasing antibiotics. And so once you have a few studies, you got to do meta-analysis, right? People are just sitting out there waiting for enough data to do meta-analysis. So there have been two. One that was published here in AAC and another one that was from the Cochrane group. And they included slightly different populations, but their basic conclusions were the same. Mortality, no difference. ICU admissions, no difference. Antibiotic use significantly decreased. Now, there's a lot of heterogeneity. Why was there a lot of heterogeneity? Well, part of that was, these trials ranged anything from VAP down to outpatient respiratory tract infections. And so the percent of people who get antibiotics for VAP is like 100%. And for outpatient respiratory tract infections, it's significantly lower. And so there's a lot of heterogeneity in those findings. The one thing I would point out is that in the Cochrane analysis, they actually found decreased incidence of treatment failure. And so some suggest that not only is it safe at decreasing antibiotics, but maybe there's some clinical benefit to using it as well. So all of these are research settings. And I'll tell you, the problem with all of these is they're done almost exclusively in Europe. There's virtually no US data on this. And that has to do with some funky things that the FDA thinks about with procalcitonin, and that, the companies who do this would love to do a stewardship study with procalcitonin to get an indication, but the FDA has some interesting ideas about gold standards and how they think they should do the studies that are very different than like how I would design the study or how the companies would. So I don't know if we're going to see those studies done in the US unless they're sponsored by some other institution like AHRQ. So does it work in the real world setting? An important question to answer, and I don't think we have all the information on that. This was a study done as a prospective multi-center observational trial, same population. What they did is they rolled procalcitonin out in a bunch of hospitals. They gave some physician education. They said, go to it, let's see what happens. What they found is, as you'd expect, patients who got procalcitonin measured for these situations were sicker, more immune compromised, and there was more overruling. So the population it was used in is a little different than in the studies. Not surprising, that's typically what we see. But even with that, antibiotic duration was significantly shorter. And I think this is the interesting thing here. So this was this pro-hosp control group, 8 days of therapy. This is the pro-hosp PCT group, 5 days. The pro-real, which was this observational trial, 6 days. So not as good as research setting, but still better than the control setting. And then they followed all these people, and they didn't see any increase in complications, mortality, anything bad necessarily happening to them. And they had less antibiotic side effects. So there was one U.S. center in this study, and they had like 25% compliance with the algorithm. So not fabulous. So my conclusions on this, and I'd encourage you, there's a ton of randomized controlled trials out there, is that PCT-based antimicrobial use in lower respiratory tract infections is able to decrease antibiotic use without adverse events. There may even be some clinical benefits, like less antibiotic side effects. And the impact of that is going to vary depending on the syndrome you're evaluating. So much more impact in COPD, bronchitis, things where we see less need for antibiotics. So that's lower respiratory tract infection. Let's talk about sepsis. I don't know if you guys are like our hospital, but everybody's interested in sepsis. Why are they interested in sepsis? Well, there happen to be these core measures that are out there that, sort of drive everybody getting really excited about this. What sepsis is just got redefined. I personally am a big fan of the new sepsis definition, because, and I'll just editorialize here, the old sepsis definition meant they have sepsis vancomycin for everything. Skin soft tissue vancomycin, pneumonia vancomycin, UTI vancomycin, because it's sepsis, right? It's not UTI anymore, it's sepsis. And so it sort of turns off the brain and turns on the vancomycin. And so I personally am a big fan of the new definition, because sepsis really means something. It's the old severe sepsis. But it's going to take a while for us to all sort of get our brains wrapped around that, which is not easy. So, as you know, there's this horrible thing called SIRS, which is both not sensitive or specific. And in this bucket falls people with burns, people with trauma, people who are post-operative, and then you have to sort out whether they have an infection or not, and it's just kind of a mess. The problem is we know that early therapy decreases mortality in severe sepsis and septic shock. But the really non-specific definition, our cultures take time, and so our response is sort of to just throw antibiotics at it and wait and see a couple days how things sort out, and then stop maybe. So it'd be nice if we had a rapid and accurate biomarker to help us out. And so this is the one study that has some of that sensitivity stuff in it. So pretty much all the studies look like this for sepsis and procalcitonin. They're mostly compared to CRP, and they always beat CRP, except in kids. In kids, they're about equal. But in adults, better, more sensitive and specific for sepsis. So the ROC here, 0.925. This is a pretty good study. They don't all look like this. In the meta-analysis, it's running in the upper. I think I have a meta-analysis, actually, on my next slide. So there have been a bunch of the most recent, if you want to read one, and this is the best one, this one from Lancet Infectious Diseases. The thing I really like about it is the discussion. So they had 30 studies. Sepsis prevalence varied hugely. Their pooled sensitivity and specificity, they weren't that fabulous. But 0.85 is pretty good for a test. It's not quite 0.9, 0.95, but pretty good. The problem is when you start to think about things in likelihood ratios. Because the way these are all done is procalcitonin is dichromatous outcome. Positive versus negative. Well, we know in procalcitonin, a 10 is much more meaningful than like a 0.4, right? Or a 0.7. Somebody has 10, boy, that's really suggestive of bacterial infection. And so you can't really statistically take that into account as well as you'd like. And so that's where I think the discussion on this paper makes the point really well. And so I'll give you my take before I show you the data, is I think this is really useful data. Really useful to evaluate, really helps to assist in the diagnosis, particularly in our ambiguous patients. It can be very useful, I think, in early stopping, but I think in our really sick patients, our tendency is to treat and then let's sort out. I think that's somewhat reasonable. I think we have to be guarded. As a guy who does antibiotic stewardship, we have to be careful. If we use lots of antibiotics, we're going to see resistance. And so this can help us to sort out those ambiguous situations. But again, we can't base all our decisions on a single lab value. You have to put it into the context of the patient, which is sort of a no-duh. It's what you tell all your trainees, right? We don't base anything on one lab. So I'm going to show you two randomized control studies on sepsis therapy. So the first one was this PRORATA trial, multi-center, randomized, open label. Their goal was to show non-inferiority of procalcitonin management. They took patients who were admitted to the ICU who'd just been started on antibiotics they thought had bacterial infections. They didn't include kids. They didn't include heavily immunosuppressed patients. They didn't include people who are going to get antibiotics for a long time with endocarditis or osteo, because you're going to give them antibiotics a long time anyway. It doesn't really matter what the procalcitonin is. And people who are going to die in the next 24 to 48 hours. And they randomized them to either usual care or procalcitonin guided management. And what they used here was a slightly different algorithm. What I'll point out is they used 0.5. Now, why did they use 0.5? Well, most of the sepsis diagnostic studies have used 0.5. Why 0.5? Well, to start out with, that was actually the lower limit of detection of the original assay. About 8 years ago, 10 years ago, new assay came in the market, came down to 0.05, so tenfold better detection. Second thing is there's just a bit more cytokine, inflammatory noise, stuff going on in the ICU patients. And so you're just shifting that cutoff point to improve the specificity of your diagnosis. Because any sort of sensitivity specificity is really just where you put that cutoff of what I consider positive. If you want to detect everyone, you set it really low, and then you get lots of false positives. And so what they did was, this was initial starting. They measured these. It was greater than 0.5. They said start. And then for stopping, they said if it was less than 0.5, stop, or if it decreased by 80% from the peak, consider stopping. These are the outcomes. No significant difference in mortality, although by 60 days, started to see maybe some early increase in mortality in the PCT group. Antibiotic use was significantly decreased here in this Kaplan-Meier type curve. You can see antibiotic use was significantly decreased in procalcitonin. The duration of first antibiotic course was cut by almost 4 days, but adherence was kind of lousy. It was like 50%, which is sort of what you'd expect. It's a higher stakes game in the ICU, and so clinicians are a little harder to, get them to do things. Even doing antibiotic stewardship, it's harder for people to say, well, the culture showed this. Whoa, okay, I don't know. I'm nervous. My patient's still sick. So anyway, if you do stewardship, you have those conversations. But decrease. So one of the arguments or problems with the study was done in primarily German centers, little higher antibiotic duration that you might expect, 10 days. The new FACP guidelines say 7 days for everything, no matter the pathogen. And so our typical course should be 7 days for most things we're treating. So that was one of the arguments, that maybe this was done in a center where what if we did in a center where the standard of care was 7 days? Would we still see a benefit? And so that study was actually just published in Lancet Infectious Disease. It's a multi-center randomized trial comparing PCT-guided therapy versus usual care. Very similar, but done in the Netherlands. If you know anything about antibiotics in the Netherlands, they're very restrained in their antibiotic use. They have very low levels of resistance. They have very aggressive antibiotic stewardship. They have some of the lowest antibiotic use in Europe, as opposed to, say, if you went to Southern Europe, where it'd be the total opposite. And what they did is they used the same algorithm as I showed you from that previous study, but they only looked at it for stopping. They didn't look at it for starting. They basically assumed people are going to get started on antibiotics, and we're probably not going to stop. And so we'll measure daily, and when you go below 0.5 or 80% off the peak, we recommend stopping. Compliance here was about the same at day 1, but by day 2, 97% compliance. Their groups were well matched. High rate of mechanical ventilation, I think 85%. Pulmonary infection is the most common infection, followed by intra-abdominal and UTI. And about 95% of patients got vasopressors, which I think may be a little different than we might see in the U.S. And so what did they find? What they found is their measure of antibiotics they used were defined daily doses, which is just another way of measuring antibiotics, decreased about 3 doses. Duration of therapy decreased about 1.5 days. And this was the interesting thing in the study. Mortality, both at 28 days and at 1 year, significantly decreased in the procalcitonin group. Why was that? I'll talk about that in a minute. Reinfection rate, slightly higher in the procalcitonin group, but this was actually a very subjective outcome. It was sort of asked the clinicians if they thought they were reinfected. Antibiotic reinitiation was no difference between the groups. As you know, people in the ICU were sort of high risk for getting another course of antibiotics. No difference in length of stay. What you can see here is this is the mortality data. Significant decrease in mortality. So why the decrease in mortality? I have a couple slides sort of laid on that we'll talk maybe a little bit about this. But the thought is there's two kind of ideas. One, we're able to actually sort out what's going on. Procalcitonin was low, and we said at day 1, rather than giving a bunch of fluids and antibiotics, we said, oh, wait. Procalcitonin staying negative, maybe that's not pneumonia, maybe that's heart failure, and we need to change what we're doing. Help people sort of sort out diagnostically better what's going on. The other thought is we took away these antibiotics, which are maybe bad for patients. There was another study, which I don't have in this deck, but it was, what they did in this study was they did an escalation study. I talked about how rising or elevated procalcitonins signal something's going wrong. In this study, they randomized people to usual care, or basically if they had a rising or elevated procalcitonin that wasn't going down or was rising, they did stuff. So they started broader spectrum antibiotics, and they did more imaging, and they did a bunch of stuff to people. And the outcome of that study was no improvement in patient outcomes, and actually worsened in the procalcitonin group. Longer time of event, more renal dysfunction. And so why was that study, that sort of management, bad? Well, it's because of what they were doing. They were routinely imaging, adding antibiotics, doing things to people based on a lab value. We don't do things based on lab values. And I think it just illustrates the point that all of the things we do to patients, we need to think about the other toxicities. Antibiotics are toxic. They are bad for patients. I tell my trainees, more antibiotics are not better. They're probably worse for your patients. Imaging's not better for our patients, probably worse. And so that was the main, because that was really the only difference between those groups, more antibiotics and more imaging. So that's one thought, less antibiotics, better for patients, sorting things out better. But again, very suggestive that, maybe there's some clinical benefit to this management as well. So this is a meta-analysis. It's a little older, doesn't include that study. As you can see, this had like 1,500 patients, which is way more than in this meta-analysis. So very strong study, but basically the meta-analysis came to a similar conclusion. No increase in mortality, decreased antibiotic use, maybe a questionable recurrent relapsed infection, although not measured real well. So we'll have to see the answer on that. At 5 days, that's the thing. They're using 5 days of antibiotics as their median therapy in the ICU. Maybe we're sort of hitting the floor of what we can do in antibiotics. Now that's for the population. For individual patients, we can certainly cut things down, I think, depending on what's going on. So some of the issues with ICU studies, lots of overruling, selective populations. Renal dysfunction is an issue in these ICU studies. And then, the other thing was standard of care. That SAP study that I showed you really addressed this issue. This is something I've brought up when I've talked about this before. But man, the standard of care in those ICUs is 7 days. So my take on it, seems safe, particularly in antibiotic discontinuation. I think, again, we need a U.S. trial. We don't have one right now. Particularly useful in early discontinuation. So whenever you talk about lab tests, you want to bring a new lab test on, the question you get from your lab director or whoever's in charge of that is, well, what's it going to cost, and is this going to make us money or cost us money? Is it cost effective to do this? And so anytime we got to bring something on, we got to say, well, here's how it's going to help us save money. So the answer to all cost effectiveness things are, it depends, right? That's always the answer for cost effectiveness. Depends on how much a test costs, how often you're going to use it. Are you going to use it every day, every other day? Are people going to adhere to it? If people don't adhere to it, who cares how much it costs? It's a big waste. How much is it going to cost to buy the equipment? Am I going to have to put new equipment in? What's the antibiotic use that's going to be influenced based on this? How long do people typically use antibiotics in our facility? And then what about things that are harder to measure, like C. diff prevention and renal dysfunction from antibiotics? Typically, when you're making these cost-benefit analyses, you're like shorter length of stay, drug costs. How do you put C. diff in there in that? And so this is a pretty simple cost analysis done from that meta-analysis I showed you. This was a Canadian group, and what they figured was basically their model was 6 daily procalcitonins. Procalcitonin management, cut your antibiotics by about 2.5 days. And what's the cost breakdown? So what they found is if you're using cheap antibiotics, it's actually more expensive to do procalcitonin management. If you're using average cost, it's cheaper. If you're using expensive things like linezolid and meropenem on everybody, it's a big cost saver. And so the answer really is it depends. Now, there have been a couple of cost models published. There was one cost model published in Infection Control Hospital Epi that basically showed if you can decrease renal dysfunction and C. diff by even a little using this, it's a cost winner across the board, because those are very expensive conditions resulting in extended lengths of stay. So if you can cut that, it's good. I'm going to show you next just a brief look at some of our experience. This is a retrospective cohort of 100 ICU patients with sepsis that had at least 2 procalcitonins. We basically bucketed them into 2 buckets. They adhered to the algorithm or they didn't. They might have not adhered because they didn't stop when the PCT was low, they didn't change when it was going up, or they stopped it before PCT was what we consider normal. Our groups are well matched, and these are the outcomes. This is small, and so sort of, you have to take it with a grain of salt, but antibiotic duration decreased, antibiotic defined daily doses. So not only was the overall duration of days people were getting antibiotics, but also the number of antibiotics people were getting was decreased. ICU length of stay was shorter, hospital length of stay was shorter, and the rest of this was kind of a wash, other than relapse was a little higher in the non-adherent group. I don't know why that is. I think that could be confounded. So again, I think we have to take this with a grain of salt. But again, there's one other study about this size from a Michigan ICU that showed very similar findings to ours. So again, some early US data. Now you could argue, well, maybe the adherent patients had better doctors, which is always the argument with these. Those adherent docs were the good guys who knew what they were doing, and the non-adherent guys were sort of just going willy-nilly and not paying attention. We can't assess those things. All right, so let's move on and talk about Procalcitonin Plus and some sort of more outside-the-box stuff. This was an interesting study where what they did was they took patients with these non-pneumonic lower respiratory tract infections, and they randomized them at a U.S. institution to standard care or Procalcitonin plus a rapid multiplex viral PCR. So the BioFire, if you guys are aware of it, the BioFire rapid pathogen panel, bunch of viruses, few bacterial pathogens. And what they found is using that in the PCT group, 40% of people in that group had a virus detected, and over 80% had a low procalcitonin. They wanted to comply with stopping, and they found about 64% did. What they found is a decrease of antibiotic use, but it wasn't significant. Overall, it was 3 versus 4 days, and in the compliant, 2 versus 4 days. What was the problem with this study? Well, the problem was it's underpowered, and they actually confounded their own study because they did some education when they rolled all this out. And so the year before, antibiotic, 6 days. And so in their control group, it had already dropped 2 days just by doing education and not even by doing any of this testing. And so I suspect if they'd done a larger population, they probably would have found the same findings. But, their education was too effective, and it dropped their control group to 4 days. So, either way, it's a win. Less antibiotic use. It's a good thing. Either way, in stewardship, we'll take our wins however we can get them. All right, some more outside of the box stuff, and stuff that I'm not using Procalcitonin for, but Procalcitonin heart failure. Some interesting emerging stuff on this. This study over here took all the patients in that PROHOS study, so that big randomized control trial, and they took all the people with heart failure diagnosis. And they just looked at them so this is a subgroup analysis of a randomized controlled trial. Okay, so hypothesis generating. Okay, if anybody remembers the old linezolid data that Pfizer did the same thing with about how they said linezolid was so fabulous. So they did. They cherry picked all the people out of their studies and said linezolid was great. And then we did a randomized trial. It turned out to be about the same, which is fine. It's about the same. So it's hypothesis generating. But what they found is people with the PCT guided had much better outcomes than those in the control group. And so why is that? Again, I think it's helping people to sort out the diagnosis sooner. So another study that looked at procalcitonin levels in people with acute heart failure. And I got to tell you, our cardiologists are not measuring procalcitonins. But what you can see here is the higher the procalcitonin was, and these are people without infection, increased mortality. So what does that mean? I suspect that's underlying physiologic dysfunction in the patient. And what you can see is the inflection point here is really in the low values. And there's another study that looked at it. Basically, their cutoff for what was high was anything over 0.25. And so there's some emerging literature, I think, in other conditions. Maybe so, I don't know. We shall see. But I think this is interesting. I think we're sort of seeing where biomarkers can help to drive us and identify patients. And I really think, particularly for this heart failure stuff, I think it's really the diagnostic utility of sorting that out. Because that's always the thing. Well, this is AFib with RVR and some infiltrates, and the white count's a little up, and they got some low-grade fever. Well, is this pneumonia? Is this all heart failure? It's hard to sort those out. So I think combinations of biomarkers, Procalcitonin with CHF peptides, Procalcitonin other biomarkers. And that's what I want to get into next, is a little bit about other biomarkers. These are biomarkers not quite ready for real-time use. So oh boy, if you want to read some crazy physiology, you can go read about all these different biomarkers. Procalcitonin, produced by these tissue cells, CRP from the liver, these are well-defined. So we'll talk a little bit about some of these cytokines. There's vascular endothelial biomarkers like ANG1 and 2 and endokines. There's a variety of receptors like CD64 and soluble TREM1, some other co-receptor things like CD14. These are all sort of in the works. And so the endothelial ones like ANG1, ANG2, and endokines, these are released by vascular endothelium under cytokine stimulation. So sort of the same endpoint. There's some data on outcomes of sepsis in these, being worse if these are high or low, depending on the marker. Cell surface receptors like CD64 is an FC binding receptor on neutrophils. It binds IgG. It's upregulated in bacterial infections. STREM1 here, there's some nice data on STREM1 being upregulated and its utility maybe in diagnosing bacterial infection. What I'll tell you is all of these are sort of we took 100 bacteremia patients and measured these. We took 100 pneumonia patients and saw where they were and added in 100 normal patients. So they're where Procalcitonin was 15 years ago. So these are a ways away from being in clinical practice. Cytokines, IL-6, IL-8, TNF-alpha are probably our more promising ones. People are particularly interested in sepsis because, as you know, sepsis has both sort of a pro-inflammatory and an anti-inflammatory cytokine drive that go both ways. Some people think first it's pro and then anti. Other people think now it's both at the same time, and so you're both immune stimulated and immune suppressed at the same time, and trying to tease all these out. That's why all those other therapies for sepsis haven't worked, because it's so complex, nobody can sort it out. And then there are immunomodulators like T regulatory cells, PD-1 and PD-L1, and then B and T cell leukocyte antigen 4. So these are all sort of different local inflammatory. So these are cells that actually modulate inflammatory states. So people are trying to measure different levels and different profiles to sort out, can we identify people with infection? I'm kind of just glossing the surface here because it's a lot of basic science-y stuff. So these are, the last two I'm going to give you are two studies that were just in JAMA. They looked really interesting when I first looked at them, but then I read them, I'm like, all right, okay. What I'll tell you is this is their innovations in healthcare delivery. So there's a reason they publish these studies. They're interesting, they're hypothesis generating, but they might make it into clinical infectious disease. I don't know. They're sort of interesting. But what they did in this is they took 279 infants, 89 with bacterial infections, and they did these RNA biosignatures. And that's what you have here. The red is like bacterial infected patients and what genes were active, and the 19 control. Anyway, I can't interpret these scatter plots, but they got computers who can do it. And they basically found 66 classifier genes that had an 87% sensitivity and an 89% specificity for diagnosing bacterial infection. So interesting. Second study, basically what they took was 240 kids, and man, they pulled these from a bunch of different sources. They had like 40 meningococcus patients and 70 normal patients and 50 patients they thought had bacterial patients infection and 50 they weren't sure. And they kind of just pulled them all willy-nilly, and they did microarray, and they culled it down to basically 38 transcripts, RNA transcripts in these cells that were markers of infection. And then because a lot of those are sort of all produced when you have bacterial infection, they got it down to two transcripts that predicted for infection. And they used that to create a risk score. And what you can see here is in people with definite viral infection, it was really low. In people who had definite bacterial infection, it was really high. But, my problem is, in the people we aren't sure about, it wasn't really any different. And so, interesting, but I think certainly not ready for prime time. And so with that, I have some final thoughts. I think there's a lot of interesting things on the horizon. I think where we're going is combinations of biomarkers together to help us decide therapy. I think right now, Procalcitonin is the best that we have. Is it perfect? No, it's not perfect. I think it helps to have some interpretation, and I think, doing education, things like that, very important. Serial measurements are really, I think, the most effective. If you aren't going to do anything with it, I'd say, though, don't bother. You're just burning money. So don't check it if you're not going to do anything with it. Another thing I'd say is don't get it in syndromes where there's no data. I see lots of procalcitonins measured in people with skin soft tissue infections. I don't know what that means. Yeah, there's no data. I don't know how to interpret it. If it's high, they probably have an infection, but I'm going to go look at them and poke their skin and decide if they have an infection. And then you got to know what confounds it, and then you can't beat good clinical judgment. Always a good way to finish. Can't beat good clinical judgment. So with that, I'll stop and take questions. Mm-hmm. Yeah, so that's right. So the question was about corticosteroids. They shouldn't. So they target, T cells and cytokines and IgE, but they shouldn't impair, they don't impair procalcitonin. Now, I will tell you that the things that do impair it sometimes immune-wise, so our oncologists like it, but are not like big fans of it because often they can't stop. They don't feel comfortable stopping antibiotics no matter what in a lot of their highly immunosuppressed patients. I'll tell you, our transplant ID people really like it. They use it a lot. There's a lot of great data in transplant patients, not quite as strong in, say, your neutropenic patients. Other questions?
Along the same lines, is there anything we can tell yet that is a risk factor to have a false negative? I mean, because I was thinking, and we had a lot of fiascos of, I thought of a lot, but then when I think about them, are like a handful of them, like procalcitonin negative, the next day positive blood culture for Staphylococcus aureus. So
right.
Those people, you just said neutropenia isn't affected, corticosteroids don't. So what does?
So I've seen that same thing happen where somebody gets a fever, you measure procalcitonin, it's negative. 12 hours later, they have staph in their blood, you measure procalcitonin, it's greater than 150. I think the key there is if you have suspicion, you got to come back and remeasure them in 4 to 6 hours because it'll be going up. And so, yeah, it's not, I think we just catch those people early in their disease. And so while it's early, it's not like super early. So, but I've seen the exact same thing happen. If you have suspicion, again, that's why you got to go with clinical judgment sometime. I've seen the exact same thing happen. So.
And lastly, on renal impaired patients, dialysis mostly, we've seen it all over the map, like insanely high and low also when they have an infection. Is that something you see or any data on that?
I haven't. I mean, my read on it, from what I've seen, is generally the really low values, the like 0.25 or less, are useful. The 0.25 to 2-ish, hard to interpret. Some of that, I got to tell you, some of that's not super well defined, particularly in people who have acute developing renal dysfunction, who are on dialysis and timing of dialysis. It is dialyzable, we think. And so that can alter it. It's not highly dialyzable, but generally it's recommended to measure. I like to try and get to measure the levels pre-dialysis. That's where the big values and the low values are useful, but it gets a little mushy in between. What was the other comment I was going to make about dialysis? The other thing that's really hard is when you have people on continuous hemodialysis. I have no idea what it does, but I have no idea what our drugs do on continuous hemodialysis either. So, we're sort of in the dark on a whole bunch of that stuff. So,
thank you so much.
Mm-hmm. Other questions? Mm-hmm.
Guidelines that specifically say use clinical judgment rather than clinical judgment plus procalcitonin for HAP and VAP. And I guess I'd be curious if you could articulate for us why are they saying that? What is their concerns or what? Because the data you're showing look good, and I think our experience is we read the data, it looks good, and then it seems like it's somehow harder in practice.
Yeah, so I'll tell you there is less data on the HAP-VAP stuff. There are trials in VAP, but they're much less than, say, those lower respiratory tract presenting to the ED. So that's part of it. I will tell you there are a lot of academic U.S. people who don't buy the procalcitonin studies. I don't know why. but they just don't. They come to my meetings, but I got to tell you, I don't know what other infectious disease data we have with multiple randomized controlled trials with hundreds and thousands of patients. I mean, the cardiologists have those coming out everywhere, but in ID, we just don't. And so there is less data, I will say that. I'd have to ask, so one of our faculty members was the lead author on that, and I haven't had a chance to ask him why he said that, because I know he's a big advocate, and actually the one who got me started looking into procalcitonin back when I was a fellow. So my guess is there are some people on the committee who did not necessarily agree with that. And there really isn't a lot of U.S. data. But I don't know why U.S. data would be different than European data. I don't think they're really that different other than the people who practice here. So. All right, well, great. Thanks for having me.